Welcome to week 2 of Healthcare Systems and Policy class. I've enjoyed our first week together and getting to know you a little bit online. So keep those posts coming in terms of our week 2 discussion. This week, I wanted to highlight a few things from your reading. It looks like a lot when you look at the number of chapters, but the chapters are fairly short. So it should not be a burden, and they offer some really good information, some details that we might not know or understand about how the various aspects of healthcare work in our country, and in particular the underlying financing and logistics of how the finances all work and access is granted. So many of us are more on the delivery of healthcare side. So this will be really interesting, I think, for many of you to read. So a couple of background information items. We start by looking at healthcare. And again, when I'm talking about healthcare right now, I'm talking about in the United States. So we're focusing in on our system. And if we look at how we're doing, we can see quickly from our reading that the need for our healthcare services is rapidly outpacing the actual financial resources available. So in other words, we cannot fund all the needs that everyone has for services. So that means if we can't, then how do we decide where those financial resources go, and how do we limit care? Because if we can't do it all, we have to figure out what we're not going to do, not just what we are going to do. So there is this limited financial support. A couple of ways that countries have looked at it is, number one is what we call government rationing, and that occurs in a government-sponsored healthcare system. So I have a picture here on your screen from the National Health Service in Great Britain, and this is how that works. So the government determines what types of services get priority, and then they work down the list. And you'll find often, not always, every country's a little bit different, but often there'll be a greater emphasis on youth and on prevention. And then when for elderly, it moves more into what we call palliative care as opposed to rescue medicine. In the United States, we have a market-determined pricing system that basically rations based on the market. And what do we mean by this? So it means that people who can afford it purchase healthcare insurance and services, and those who have less means purchase less. So it's really based on income and wealth. So it's by the ability to pay. Now, many of us receive our health care through our employers, but that also comes with some expenditure on our part, but we also give up sometimes cash salary for that as well. So there are a lot of questions that are raised by this, and at the very last week we talked about this. The theme of this course, there'll be two things that keep popping up, which is equity and efficiency. So a lot of insurance companies view our current system of employer purchased health insurance as creating this kind of moral hazard, and not just employer purchased, but individual purchased. So in other words, it is skewed towards those who have the ability to pay. And so managed care, which means if you have more resources, you can request services that may not be deemed by society to be as necessary, and others who have necessary services can't get them. So that's that moral hazard. And one way to determine that is through managed care, where insurance companies have tried to manage individuals' care and place limitations on it. So those are the two types of systems that we see in the world today. And I sort of challenge you to figure out maybe even a third way or a better way. So in our system, health insurance plays a huge part. And, why do people ask for insurance? Well, clearly it's like other aspects, other types of insurance. We attain health insurance because we want to avoid any medical expense surprises, particularly the large expenses, unexpected expenses, and also reduce risk so that we can plan our lives and our financial futures better. And I've already mentioned employer-paid insurance. This is one of the main avenues through which many Americans receive their insurance. And it has some incentives built in. And you have, one of the things you're going to decide in this class is, are these good incentives, bad incentives? What are the consequences of these various incentives? And how should this all be revised, if at all? So one thing that you may not have thought about is that your health insurance benefits are tax-free. You are not taxed on those. And so that is an incentive for us as patients not to worry so much about asking for more expensive tests or more frequent visits or services, that if we were paying the actual proportionate share of what that insurance would cost us to get that level of services, we might not make the same choices. So we're incentivized to use insurance more. So it does alter how we regard healthcare expenses. So how does this all work? So, I mentioned that the majority of us get our insurance through our employer. So 87% of the non-elderly. So we're excluding, Medicare in this. But so insurance premiums, when we purchase insurance, have two aspects. One is that claims part, which is based on your group's experience. So if you're in a group that is a high utilizer of insurance, then your premiums will go up because your history of claims is higher. And then there's a loading charge, which is usually around 15%, and that is the cost of doing business. So think of it as administrative expense, marketing expense for the insurance company, etc. I can tell you that when I ran a healthcare operation, I purchased insurance for our employees, and I was shocked the very first time I was asked to do this, because I found out that as healthcare workers at that time, we were in a group where our rates were higher than other office-based types of companies, and we were an outpatient clinic. And I'm thinking, why is that? And the reason that I was given by the insurance companies was that healthcare workers tend to be high utilizers. And in particular, they're high utilizers of preventive medicine, which does not have an immediate payoff for your current insurance company. So I thought that was kind of interesting. So it's not just that claims experience goes up, not just because of an unhealthy group, but it can be for many reasons, right? So we do have individuals who actually go out and purchase for themselves, and the Affordable Care Act increased that quite a bit when it came into effect by creating health insurance exchanges. The problem with this was, without requiring everybody to be insured, like think about if you want to get an automobile license and drive a car, purchase a car, you have to show liability insurance. You have to show that you carry some insurance in case you have an accident. So, but there is nothing for health insurance. Now, whether you agree or disagree, it doesn't, that's an individual thing. But right now, it doesn't exist. And in Obama's original ACA, it did, but it was taken out in order to help it get passed. So what that meant was people who didn't feel that they were at high risk for high expenses, like your young, healthy folks, particularly males who are not going through childbirth or anything, they did not buy insurance. They rolled the dice because they figured it would be okay and they could always purchase it. So what we have in that case is what we call adverse selection, which means the rates that insurance companies quoted to individuals was based on everybody joining. But when that was taken away, you had people who had pent-up demand, who had a lot of medical issues that hadn't been taken care of for a while, and then those who couldn't get it through other avenues, and so they tended to be higher utilizers, and the cost was much greater. So as you're probably aware, many insurance companies withdrew. There were financial issues for the companies, and then the number of people joining was in a group that they hadn't anticipated. So besides our employer-based and individual purchase of insurance, two large groups that you're going to read about this week are Medicare and Medicaid. So what is Medicare? How does it work? So Medicare covers, we think of it as an elderly, but also if you have disability through Social Security, and there's a few other categories that are in there as well. But there are 4 parts, and one is hospitalization, one is outpatient, one is managed, sort of a optional, like managed care. That's Part C, and then Part D is your drug expenditures. So Part A, there is no cost. So for instance, when you turn 65, you're covered by Medicare, Part A, so that's the hospitalization part. So you don't have to pay a premium for that. Part B is like an insurance, so you do pay a small amount for your Part B and Part D expenses or coverage. So what we've seen though is, as we talked about last week, we have rapidly rising medical expenditures in this country, and it's driven by a lot of things, right? People are living longer, and baby boomers who are aging, which is a large segment of our population, are moving into that category. And we know that elderly are one of the most expensive groups in terms of using our healthcare system. But also, on the other side of that, Medicare has been paid for through payroll tax. So you'll see in your pay stub, Medicare and Social Security, called FICA, deductions. Well, the problem is that when Medicare was first devised, there were a lot more workers who were supporting each retiree who was on Medicare, and that, as you can see on the screen, continues to shrink. So this combination of rising demand, and reduced base of financing is not sustainable. It's going in the wrong direction. So we have to figure out some answers here. Here's a chart I took from your textbook, which gives you an idea of where the beneficiaries are and how it's grown over the years, and then what the projection is by the time we get to 2030. So you can see that the majority of expenditure is in the elderly category. All right, so there's a lot of conversation about how do we fix Medicare, right? Because obviously it's not sustainable. We're, as we'll see towards the end of this talk, we're rapidly going into more and more debt and increasing our deficits every year. So we've got to figure something out. That's not sustainable, as just mentioned. So again, when we look at reforming or revising Medicare, we have some things in mind. One is equity. Equity, think of access. Efficiency, so that we're not just wasting those dollars, that we are putting them to good use. And then, how are we going to reduce the rate of increase in Medicare spending every year? So it's growing exponentially. So is that through services or what? So here there's some suggestions, and you'll read about these in your book, and please do, because as we work through this course, part of what I want you to figure out is how you would reform the United States healthcare system. So we could raise the eligibility rate, which has been on the table for quite a while, but is very unpopular among elderly baby boomer voters, which is a huge voting bloc. So there hasn't been a lot of political willpower to get that done. One thing that Medicare has done is decrease provider payments. So that would be money paid out to physicians, hospitals, other care workers, et cetera. The problem with this is, and again, you'll read a little bit more about this, but as we reduce the amount that physicians in particular are reimbursed, many of them are opting out and just not taking Medicare. So now your supply is diminishing as well. And it's not just because they're callous. I know that in my experience and as an administrator, we lost a great deal of money on every Medicare patient that we saw. And so we had to make that up with our other, our insurance, our patients who had insurance, and through other means. So if, excuse me, if it costs us $1 to see every patient, to see a patient, and Medicare is paying us 37 cents for that, you can see that that's not sustainable either. So you're just shifting the burden of unsustainability farther down the chain. And same thing goes for, you know, your occupational therapist, your physical therapist, your everybody. So that's, you know, something that's been tried, but there's a limit to that, right? The increase in the payroll tax, that health insurance that you see on your paycheck. And again, I suspect raising taxes is not politically very popular. Another option would be to increase premiums for that Part B and Part D, which is your outpatient and your drug coverage. But again, you know, this is not popular among this large voting bloc of aging Americans. So it requires some political willpower in there. Some competition among Medicare plans. So this would be increasing the use of, say, managed care plans and that sort of thing, where the more efficient they are, and that includes high quality as well as wringing out the waste, then the better that they can deliver care, then the more business they attain, and so that competition might help. And then another idea for reform is to tie Medicare to income. So if you have a high income, then you pay more and receive less in terms of Medicare benefits. If you have a lower income, your premiums would be much lower and you would receive more in terms of benefits. So that's a lot of different ideas, and there could be some magic sweet spot combination of these, but I put politics on the screen because I've mentioned that several times just in the last couple of minutes, that, you know, our legislators need to really get serious about this. And unfortunately, if you think about it, someone who's elected to Congress, by the time they're in there and they get up to speed a little bit, even after 6 months, they're already starting to run again because they only have 2-year terms. So I don't know how we make that work, right? But that's something we're going to think about. So Medicaid is provides medical care for low-income citizens, but it also includes long-term care. And so that's a huge expense area and growing. Again, we have growing population in that area, and then the cost of longevity, people living longer, and then the cost of supporting them is so much higher, and their medical needs are higher. So a few facts here that I pulled out of your reading. It is the fastest growing expenditure in the federal budget. And in fact, it's the 3rd largest expenditure in that budget. So when the Affordable Care Act was passed, it expanded Medicaid by, which created an increase in demand for that program. So it expanded it by raising the income level and some other things so that more people would be eligible, so they wouldn't have to depend on an employer, right? But so you increase the demand, but then you didn't increase the supply of people providing those services. So again, Medicaid, as with Medicare, is difficult for healthcare providers in that the reimbursement rate is so terribly low that if you have a practice made up entirely of Medicaid, that's problematic. Now, managed care has helped a little bit with that, but so it's not easy to increase your supply of Medicaid providers, I guess is what I'm trying to say. Also, Medicaid has a state component that, in terms of how it's administered, and so there is some variation in how Medicaid patients and benefits are instituted across different states. Another thing, and I mentioned politics because I keep bringing this up because our legislators are the ones who have to make these choices, is that Medicaid beneficiaries tend to have less political power than those who are under a Medicare plan, right? So less voting power, et cetera. And so it's really up to society to figure this out and to apply some pressure on our legislators to figure this out. So some reforms also have been proposed for Medicare and that, or Medicaid, excuse me, and that includes, more managed care than what we've seen so far. And then maybe some sort of federal subsidy that goes to individuals that sort of levels the playing field across states, because some states are not doing as great a job as others, right? Another one that's kind of interesting is called federal block grants. And right now, if you want to deviate from the federal rules on Medicaid, the process is very cumbersome. So, for instance, I know in Oregon, many years ago, we led the country in coming up with a very unique way to basically ration care, but to bring some order to the system. And the state of Oregon, had to go through all kinds of cumbersome processes to get approval from the federal government to institute something that was innovative and covered more people and cost less money. So this is all tied up in that. It's giving the states the ability to, make decisions that are good for the states. And then a third one is income-related vouchers. So it's kind of a sliding scale in Medicaid, like was proposed also for Medicare. Okay, so here is, I mentioned Medicare and Medicaid together, and there's a reason why you're reading these two chapters at the same time, is that they have a huge impact on the US national budget and debt. And so if you look at our federal debt versus GDP, it's growing substantially, and the difference between the two is also growing over the years. And then if you look at the bottom part of the chart, you can see it has to do with federal spending versus revenues, percent of GDP. So there's a lot of pressure, particularly from the financial markets, and which is where we borrow our money, right? The US government issues bonds or debt. So think of something like a US savings bond or a treasury bill. So the US government goes to the financial markets to issue debt. And the markets are determining the well-being, the financial well-being of the US government in terms of how they price those. So if we continue to have poor financial management as a country, it's going to cost us more money to borrow debt, right? And because our risk goes up as a debtor. So there's a lot of pressure here to kind of get this under control. And of course, now we throw into that the results of a worldwide pandemic and the hit to the economy, and certainly in the United States in terms of on the individual level, the state level, and the federal level. So this chart's going to expand even further. So how do we fix all this? This is my question for you. So I want you to be thinking about this. I want you to be mulling this over as we work through this course. And keep in mind our two areas that we continue to focus on, which is equity and efficiency, right? Okay, so we are, as I mentioned at the beginning, in week 2. So you're reading chapters 5 through 9. Don't forget to jump on the discussion forum. I highly encourage you to get in early and to really engage. This is, as I mentioned before, the backbone of this course, and this is where a lot of learning happens and a lot of ideas. As a group, you all have so much experience and in a variety of different areas in healthcare, and this is a great way for us to learn a lot about these different aspects of our huge, huge healthcare system. So jump in there, all right? I want you to also begin thinking about your term-long project, which will culminate in a large paper at the end of the term. And in week 3, which is next week, your concept paper, which is basically your proposal for your topic, is due next week. And we really need to stick to these deadlines because they're just going to start rolling in quickly, and before you knew it, your big paper's due. So let me know if you have questions or you want to bounce ideas off me. I am happy to do that with you. Okay. As always, please don't be a stranger. If you have questions, remember the only bad question is the one that you don't ask. So have a great week, and I will see you online. Thank you.